Welcome to today's Explainer. We're putting on our medical detective hats to decode the fascinating and honestly vital clues hidden right in the shape of an infant's skull. We'll be looking at a condition that literally transforms the foundation of a baby's head. By the end of this, you're going to know exactly how medical professionals read these specific shapes like a map.
Here's our agenda for the investigation. First, the basics of single suture craniosynostosis. 2, sagittal synostosis and surgery. 3, coronal synostosis and syndromes. 4, metopic synostosis characteristics. And finally, lambdoid synostosis versus its sneaky mimics.
Section 1. Basics of single suture craniosynostosis, the foundation.
So, to understand these complex deformities, we first have to understand the core mechanism. Craniosynostosis is simply the premature closure or fusion of one of the 4 basic single sutures in a developing infant's skull. We're going to examine exactly how the premature fusion of just one of these fibrous joints completely dictates the resulting shape of the head. It is a direct cause and effect relationship that alters bone growth in a highly predictable way.
Moving on to Section 2, sagittal synostosis and surgery, the keel-like ridge.
Sagittal synostosis is by far the most common form affecting a single suture. And what's incredibly interesting here is the demographic breakdown. A massive 80% of these cases occur in males. This specific fusion produces a palpable keel-like ridge straight down the center of the head. It creates a very distinct, elongated, boat-like shape known clinically as dolichocephaly or scaphocephaly. Because of this abnormal fusion, you'll specifically notice a high forehead and a very prominent back of the head, known as the occiput.
Now you might be thinking this is just a cosmetic head shape issue, but that's actually not the case. This is exactly why surgical intervention is often medically necessary. Up to 44% of patients with non-syndromic sagittal synostosis experience elevated intracranial pressure. The brain simply doesn't have the physical space it needs to expand properly.
When it comes to actually fixing this, surgeons follow a very exact step-by-step criteria. They perform what's called a linear strip craniectomy, cutting from the coronal right back to the lambdoid suture. Timing is absolutely everything here. It's best performed within the first 3 to 6 months of life. And that removed strip of bone must be substantial, at least 3 centimeters wide. Interestingly enough, despite some past practices, there's actually no proof that interposing artificial substances, like placing celastic sheeting over the bone edges, helps prevent the fusion from coming back.
Because we're diving deep into the details, it's vital to note a critical surgical warning. Surgeons have to take immense care to avoid dural laceration and any potential injury to the superior sagittal sinus that lies right beneath the bone. After surgery, the child is followed closely, and reoperation is necessary if the fusion recurs before 6 months of age. If they end up waiting until after a year old, a much more extensive cranial remodeling is usually required. Let's move to Section 3. Coronal synostosis and syndromes, the harlequin eye.
Coronal synostosis accounts for about 18% of cases. But unlike the sagittal suture we just talked about, this one flips the demographic script. It's actually more common in females.
When the coronal suture fuses on just one side, it causes a condition called anterior plagiocephaly. This presents as a flattened or even concave forehead on the affected side. Fascinatingly, the bone above the eye, the supraorbital margin, gets pulled higher than the normal side. This produces what is known clinically as the harlequin eye sign. Without treatment, the orbit rotates outward, producing amblyopia, the cheek flattens, and the root of the nose actually deviates toward the normal side. On the flip side, bilateral coronal fusion, where both sides close prematurely, causes brachycephaly. This results in a very broad, flattened forehead, which is often accompanied by shallow orbits and progressive proptosis, meaning the bulging of the eyes. We see this bilateral fusion frequently tied to broader craniofacial dysmorphisms. For instance, Krausen syndrome brings midface hypoplasia, while Apert syndrome is uniquely accompanied by syndactyly, or webbed digits.
The approach to surgery for this has evolved significantly, which perfectly highlights how medical consensus shifts to address complex orbital involvement. Historically, a simple strip craniectomy was used and it often yielded good cosmetic results. But the current standard recommendation is a lot more involved. It requires a frontal craniotomy paired with lateral canthal advancement. This actually involves temporarily removing the orbital bar to properly reshape the brow and the eye sockets.
Section 4, metopic synostosis characteristics, the triangular forehead.
Metopic synostosis has an incidence rate of roughly 1 in 15,000 live births. And much like our first case with the sagittal suture, this condition predominantly impacts males, making up about 75% of the cases.
The abnormal closure of the metopic suture literally pinches the front of the skull into a highly recognizable triangular profile, which is a condition called trigonocephaly. You'll see a prominent midline ridge running down the forehead, and this pinching effect draws the eyes unusually close together, a clinical sign known as hypotelorism.
Now, isolated physical findings like this are often profound clues pointing to much deeper genetic profiles. A significant number of infants with this specific triangular forehead also present with a 19p chromosome abnormality and associated developmental delays. So the shape of the skull literally becomes a diagnostic flag for systemic genetic conditions.
And finally, Section 5. Lambdoid synostosis versus mimics, the great deception.
True lambdoid synostosis is exceedingly rare. It accounts for at most 1 to 9% of craniosynostosis cases, and it involves the right side in about 70% of those occurrences. What's totally unique here is that unlike the raised ridges we saw in sagittal or coronal fusions, a true lambdoid fusion actually presents with an indentation along the suture line.
Understanding these geometric differences is the absolute master key to decoding this condition. Because lambdoid synostosis flattens the back of the head, it looks incredibly similar to standard positional flattening, but you have to look closely at the clinical differences. True lambdoid fusion creates a trapezoidal head shape, where the ipsilateral ear, the ear on the flat side, is pulled backward. Postural plagiocephaly, the mimic, creates a parallelogram shape. And crucially, the ear on the flat side is shifted anteriorly or forward along with bulging on that same side's forehead. The position of the ear completely flips the diagnosis from a surgical fusion to a non-surgical postural issue.
It is vital to distinguish these two. Postural plagiocephaly is a positional deformity and is absolutely not a craniosynostosis. It is a molding of the skull from outside pressure, not a premature fusion of the bone.
So what exactly causes this really common mimic? It systematically comes down to 4 distinct positional pressures placed on the highly pliable infant skull. First, it could be decreased mobility due to prematurity or chronic illness. Second, abnormal postures, like congenital torticollis pulling the baby's neck to one side. Third, it might be intentional positioning by parents for safe sleeping. Or fourth, intrautero etiologies, like crowding before the baby is even born.
I want to leave you with this final thought. The 1992 recommendation to place newborns in a supine sleeping position on their backs drastically reduced the risk of sudden infant death syndrome, but it simultaneously caused a massive spike in intentional positional flattening. As these positioning practices continue to save countless lives, mastering the subtle diagnostic clues of the infant skull has never been more vital for the modern medical detective. Until next time, keep analyzing the details.